Hello, I'm Claire Coles from Emory University School of Medicine. And today I'm going to talk to you about interventions following prenatal exposures, using as an example the case of fetal alcohol spectrum disorder, or FASD. I have no conflict of interest to report. I would like to acknowledge the support for our research of the Centers for Disease Control and Prevention and the National Institute on Alcohol Abuse and Alcoholism. I'd also like to thanks to Sharon Page Whitaker, as well as the staff of the Center for Maternal Substance Abuse and Child Development, and the parents and children participating in our studies. The deficits that we see in individuals who are alcohol affected result from the effects on the CNS of prenatal alcohol exposure. And these include reduction in overall brain volume, malformations and reductions in volume of gray and white matter, thin and missing corpus callosum, which of course are the bundle of nerves that connects the two hemispheres of the brain, alterations in brain activation, and alterations in functional connectivity. There are many consequences of this impact on the central nervous system. Young children have developmental problems, and older children demonstrate problems with cognitive development that may be either global or specific. Behavioral consequences are also common. Effects on the brain and on the child's behavior and development will vary depending upon the extent and timing of prenatal exposure. We know that these can be very different. Exposure during the first trimester may have different effects than exposure during the third trimester or exposure that continues throughout pregnancy. We know that exposure for a short period of time will differ from exposure that extends for a longer period of time. In addition, there may be other issues, familial and environmental factors that also impact the child who has prenatal alcohol exposure. These factors may be negative and may contribute to more severe outcomes for the child, or they may be positive and they may ameliorate or remediate the impact of the prenatal alcohol exposure. As a result, when we're planning treatment for FASD, we have to consider the needs of the individual child. Individualized assessment is necessary to determine the child's strengths and weaknesses. And this may involve a number of different assessments and different types of information. It's important to have a developmental history, which probably includes access to birth records. We also want social and caregiving history, so we know the early experiences of the child. A medical evaluation carried out by a pediatrician familiar with the effects of prenatal exposures is also very important. To understand behavior and learning, we have to have a psychological and perhaps a neuropsychological evaluation. And because there are so frequently academic problems, it is usually important to have a psychoeducational assessment as well. Based on all of this information gathered by the different experts, we can develop an individualized treatment plan using the expertise of this multidisciplinary team to provide for the best possible plan for treatment of the affected child. One of the areas that frequently brings a child to the clinic for care involves impairments in self-regulation. And this can occur both in terms of emotion and behavior and in terms of cognition. The child who is affected may have a number of different concerning behaviors, frequently characterized by changes in mood, irritability and negative affect, behavioral problems, and may also have cognitive implications like difficulty in coding new information, difficulty in shifting attention from one aspect of the environment to another, which is called cognitive flexibility and is important in finding new solutions to problems that are not yielding themselves to the current strategies. The child may also have difficulty sustaining mental efforts, so that when presented with a task, they are not able to stay with it long enough to finish it or to learn what they need to learn from the situation. We also frequently see impairments in inhibition or impulse control. In thinking about what's going on with the child, we turn to optimal stimulation theory and its effect on state regulation. The behavior of an individual can be considered in terms of state, in which we regularly move from one state to another throughout our day. Sleep or drowsiness is the state of lowest arousal, whereas upsettedness or hyperactivity might be considered the highest level of arousal. Typically, we want to be in an intermediate state, one of a calm alert state, which allows us optimal access to environmental stimulation and ability to focus our attention. Much of the time when we're working with a child who has behavior problems, we're trying to get them into the right state. Executive function is one of the ways in which most of us achieve appropriate state regulation. And this is a set of cognitive processes which we hypothesize to be the basis for regulation of thinking, behavior, and emotional responses. We include in executive functionings memory, working memory, planning, judgment, inhibition, and the ability to switch attention or cognitive flexibility. Those things which are most relevant for the issue of self-regulation are planning, sustained attention, inhibition, and this cognitive flexibility. These things are supported by efficient activity in the prefrontal cortex, which, as you know, is the last part of the brain to myelinate, developing over childhood and finally maturing in early adulthood. Deficits in executive function can lead to impairments that affect behavior and learning. So inefficiency in the frontal cortex can lead to problems with inhibition of impulsive responding. It can interfere with regulation of basic attention and impairment in planning and organization. Another area that's often a problem is mental manipulation of information, such as is required for doing a math problem in your head, for instance. Another area that we know is a problem is cognitive flexibility, or the ability to change strategies or thinking about things in more than one way when that becomes necessary. Abstract reasoning can be affected, and we often see that affected individuals have problems generalizing or applying knowledge in new situations. One construct that can be very helpful in thinking about these issues is metacognition. Metacognition, of course, means thinking about thinking, and it is considered a higher order cognitive skill, and one which is developing over childhood and being more and more refined. Metacognitive regulation is important for self-regulation and in control of arousal and behavior. And we typically think of it as including planning for future tasks, monitoring our activities, and evaluating the effectiveness of our actions. It's important to think about how this can be useful in working with children who have neurodevelopmental disorders, particularly those associated with prenatal exposures. We have developed a technique, FAR. This is a metacognitive strategy that supports increased self-regulation and reflection. The first element is F is focus and plan. The second, A, is act. And the third, R, is reflect. We've developed some cards which we use with children to help them implement these strategies. First, we ask them to look at the situation or problem that they have to solve, listen carefully to the instructions about the problem, and to think about this with your brain and make a plan. After making a plan, you can act and do the things you need to learn to carry out your plan, learn what you need to learn, and carry out other activities. Finally, we ask you to reflect on what you did and what was effective. Did the plan go to work as you intended it? Were there problems? What might you do in the future? We then developed a program to improve metacognition and behavior in young children, which we call MILE, or the Math Interactive Learning Experience. We chose to focus on mathematics because this is an area that is frequently impaired in alcohol-affected children. They frequently have impairments across the board in terms of their academics, but most of these are consistent with their overall ability level. Mathematics, however, frequently is specifically impaired even when other elements of learning are preserved. We developed a program with a number of elements. These include parent education, an instruction element for children, specific training for instructors of the MILE program, and finally, a train-the-trainer curriculum for those people who would like to use the program more widely. The first element, working with parents, involves empowering caregivers and creating partners in the treatment of children. There are two elements of this. One involves understanding the disability and the educational system, and the second involves understanding how to manage behavior. The first workshop focuses on how the prenatal exposure has affected the child and what elements of learning and behavior are impacted. It also talks about how the parent can interact with the educational system effectively in order to help the child meet their needs within the school system. The second workshop involves teaching children effectively, teaching the parent the strategies to manage the child's behavior and help regulate their behavior. Second element of the program is a direct intervention with the child. Our goal here was to improve mathematics achievement in children and to improve effort control of behavior by the child. There are a number of curriculum elements which we developed, which are designed to focus on specific areas of deficit at specific points in the developmental process. There are a number of specific elements to the math intervention process that include a parent component. Parents were taught about math development in FAS, and they were also encouraged to work at home to stimulate math activities, and they had specific exercises in order to do that. There was also a child tutoring element, which included a 6-week one-on-one tutoring sessions using an individually focused and developed curriculum. There was also an element of teacher training in which the child's teacher received a manual about FAS, information about specific neurodevelopmental profile or deficits that were inherent in this particular child, and how our 6-week IEP supported program would in fact address these particular areas of deficit. In order to evaluate whether this was effective, we had a clinical trial in which half the sample was given these elements of the intervention and the other half was not. There were certain specific elements that were involved in the teaching of the child during the 6-week program, and they were designed to target specific weaknesses associated with neurodevelopmental disorder associated with the prenatal exposure. We were careful about the pacing of instruction, and because there is a diminution in the speed of processing in alcohol-affected individuals, we keyed the instruction to their specific processing rate. Because they have difficulties with encoding, we incorporated frequent review and repetition in the learning process. Because they had difficulty conceptualizing abstract constructs and symbols, we incorporated manipulatives in our learning process to demonstrate spatial concepts and limit interference when creating mental representations. So for instance, if we didn't just give them the symbol 2, we gave them 2 elements to represent 2 so that they would be able to link these concepts. We also employed guided mediation to facilitate thinking, concept formation, and to provide immediate feedback to adjust learning if there were problems encountered. At all times during this process, we incorporated FAR, which, as you may be aware, is a modified version of Plan, Do, Review, first conceptualized by the High Scope program. Finally, we were careful to include number writing instruction because many of the children, as you can see from this graphic, had very poor number writing skills. And if they could not write a number clearly enough to understand it later, it was very difficult to develop appropriate math skills. We found as a result of this study that there were significant gains in both mathematics and behavior in those children who received the intervention. There were positive gains as a result of parent education. There were particular improvements in arousal regulation, behavior, and learning in the children. And the parents developed better behavior management skills. We found that it was important to have individualized intervention plans in order to scaffold according to the individual child's learning needs, and that it was important to integrate the strategies we were teaching the child with what the parent and family were doing and with what was going on at the school. We found that instruction necessarily had to support growth in the areas where there were specific deficits, which was not the same for each child. So that was the need for the individualized IEP. And that we had to target those areas in which there was a deficit. We also found that learning was most effective when it incorporated metacognitive strategies, ways to integrate information, and frequent review and repetition. We were very interested to find with MILE that not only did we get a significant improvement in math function, but the children we were working with had significant behavioral improvement as well, both at home and at school, as reported by parents and teachers. That prompted us to develop another program called GoFar. GoFar was specifically designed to work on behavioral issues that were recurring with the home, and particularly around the area of adaptive function, cleaning your room, getting dressed, brushing your teeth, and things like that. And we developed a program that was somewhat analogous to the MILE program, but worked specifically with parents. And we also incorporated a serious computer game to allow children to learn GoFar and develop skills through this computer program, which they all loved. We found that the children who had GoFar and who learned FAR demonstrated significant improvement in their behavior. What does this mean for children? Most children can learn to use these metacognitive techniques to improve behavior regulation. Initially, it does require guidance from parents and professionals. But once children get it, it does provide them with a better way to approach problems and the issues that come up in daily life. Children who can use metacognitive techniques have fewer behavior problems, and they experience a sense of accomplishment and greater control over the activities of their lives. And we also have found that the FAR technique and others like it can be applied to many different situations and for many different children. Thank you for your attention. I'll be happy to answer any questions you have about the programs and to any comments you may have. Thank you.